Our next speaker will be Dr. Nadia Waheed from Boston, discussing integrating OCT angiography information in the management of patients with retinal vascular disease.
Thank you, Nitin. I've lost my signal here. Good, I have it now. So I'm just going to talk, just rapidly run through what OCT angiography has taught us about retinal vascular diseases. And of course, the king of retinal vascular diseases would be diabetes. So most of my talk is focused on diabetic retinopathy. Here are my financial disclosures. I think when we're speaking about evaluating the retinal vasculature with OCT angiography, it's important to understand how the retinal vasculature develops and what the normal retinal vasculature looks like. And as all of you are familiar, the retinal vasculature development commences from the optic disc around 14 to 15 weeks of gestation, and it proceeds centrifugally from there on forth. And the superficial or the inner layers of vasculature, which is the larger blood vessels, are laid down first, and then you start developing these, they start giving rise to these plexi later on in development. And at the end of the day, when you're looking at the macula of a normal subject, you have, at least 4 and potentially up to 6 vascular plexuses that you're looking at in this area of, in the macular area that you're imaging with the OCT angiography. So, you have some remnants of the slides are missing. So I have the slides over here, but I have them back up here. Great. Okay. So you're looking at these remnants of the radial peripapillary capillary plexus, which Vas had mentioned, that the plexus that extends out from the optic nerve. And then in the retinal ganglion cell layer, you have this superficial plexus. And generally, our OCT machines will collapse these two together, and these will become the superficial capillary plexus. And then you have, an intermediate plexus that lies here in the inner margins of the inner nuclear layer. And then you have the deep capillary plexus right here. It's the outer margins of the inner nuclear layer. And often, the machines will collapse these two together as the deep capillary plexus. And so when we look at FA and are doing FA of the retina, we're primarily imaging just the superficial retinal plexus because of the absorption that takes place as light penetrates deeper into the retina. And there have been numerous studies, including this one by Snarley, that shows that on the other hand, when you look at OCT angiography, because it's depth resolved and because there's less because it's depth resolved and because you're not looking at visible light, so there's less absorption as you go down into the deeper retina, you're able to visualize in a full retinal projection essentially both the superficial and the deep capillary plexus, and then you're able to separate them out to be able to visualize them individually, which is really not an ability that you have under fluorescein angiography. And because we're able to do that, we're starting to see things in diabetic retinopathy that we would not necessarily be able to visualize in fluorescein angiography. So independent viewing of the vascular layers enables improved visualization of capillary abnormalities in diabetic retinopathy. And here's an example. This is from our prototype swept source machine developed at Dr. Jim Fujimoto's lab that demonstrates that. Here is the total retinal projection of a patient with diabetic retinopathy. And then when you separate out the layers into the superficial, the intermediate, and the deep, you're really seeing much better the areas of capillary loss here in the superficial plexus, and you're seeing how the foveolae vascular zone has become ragged and irregular, and there's a vascular dropout around the foveolae vascular zone in this deep plexus. One of the things that we've seen as we investigate this is that diabetic vasculopathy starts much sooner than diabetic retinopathy becomes clinically apparent, and there have been several groups that have shown this. This is from one of our initial publications, and these are all patients who have diabetes but with no clinical evidence of diabetic retinopathy, as graded on color fundus photographs and looked at a reading center as well. And what you see in this particular cohort of patients is that there actually are quite significant vascular changes that you're seeing on OCT angiography. And not only are there vascular changes in the superficial, intermediate, and deep plexus, but you're also starting to see microvascular changes in the choriocapillaris, and that was something that was only previously reported on histopathologically by Jerry Luddy's group, but had never been visualized in vivo in patients using any of the available imaging devices before we had the ability to do OCT angiography. Now, what we can also do then is to try to quantitate some of these, and from a reading center or a clinical trials perspective, but also eventually from a clinical management perspective. Quantification is really very important. As all of you know, when you're managing diabetic patients, one of the things that really launched OCT per se into the management of diabetics was when we were able to quantify retinal thickness in an objective manner. And so, there's been some initial steps taken towards quantification of the vasculature in diabetic retinopathy. And so when you start quantifying this vasculature, what you start seeing is that the size of the foveal avascular zone as well as the perifoveal intercapillary area tends to increase with an increasing severity of diabetic retinopathy. And one of the earliest changes that you see in patients who are diabetic without any clinical evidence of retinopathy is that there's greater heterogeneity of that central foveal avascular zone than you see in normals. There's just a larger spread, and then as they acquire more severe diabetic retinopathy, you see that the foveal avascular zone becomes larger, it becomes more irregular in size, and that's being demonstrated. Now, quantitative OCT angiography provides information on the vascular changes that occur with diabetic vasculopathy. And so, there's several ways of quantifying these vascular changes in a more automated manner than having to sit down and draw out the foveal avascular zone and try to figure out what its size is, right? And some of the initial data on quantification came out from Rick Rosen's lab in New York. And these have been followed up by numerous other publications that look at vascular density and at quantifying the vascular density. And I think Vas presented some of this, where you skeletonize the OCTA, and then you get vascular perfusion maps or heat maps that show you what the density of the vasculature is at any point in time, and then you can follow patients with this to figure out what's happening with their diabetic retinopathy over time, and may potentially be a much more sensitive indicator of changes than just looking at patients clinically and trying to quantify all of this clinically where you may not be able to see it as well. We've also looked at other ways of quantifying vascular changes in diabetic patients. So you can look at the intercapillary area, and this is from some of the initial data that we published that shows that as you progress into more severe diabetic retinopathy, what happens is that the heterogeneity again in the size of the intercapillary area tends to increase, and so you have these larger areas where there's capillary dropout and where the intercapillary area tends to increase, and you see that visually over here in patients in controls and diabetics without retinopathy, and then with patients with non-proliferative diabetic retinopathy. And then other things that you can do arborization analysis in these patients to look at the complexity of the branching of the vascular layers. And one of the things that you see as diabetic retinopathy becomes more severe is that there's a slower rate of arborization from the foveal avascular zone outwards, and that's primarily because of pruning of the vasculature. And again, this may be another sensitive indicator of vascular loss, although it's still something that's an active area of investigation. So all of these approaches at automated quantification have primarily looked at the vessels that you're visualizing, right, and quantifying vessel area and vessel complexity. But some of the other things that you can potentially quantify, and especially important with swept source OCT angiography, where you're able to get multiple different volumes of OCT over the same amount of time, and so you're able to not only look at, say, comparing volume 1 with volume 2, but you're also able to compare volume 1 with volume 3 and volume 1 with volume 4, is that it enables you to get an idea of the speed of flow in the vasculature. And when you do that, you can use that to analyze blood flow impairment. And so, in a diabetic, for example, in this patient with non-proliferative diabetic retinopathy, if you look at the areas of microaneurysms, what you see is that they show more turbulent flow and slower flow than you would see in normal vasculature. And Professor Fujimoto will go much more into this kind of active area of research that I'm presenting over here. Now, do these changes that you see, the slowing of flow, this capillary dropout, also manifest at a macro level? And so does it affect total retinal blood flow? And again, Professor Fujimoto will present this in much greater detail, but especially in patients with diabetic macular edema, we start to see that there is a reduction in total retinal blood flow. And this is interesting because for all of us who kind of like doing and are used to looking at wide field imaging, we do start seeing this in patients with DME, where we're doing wide field imaging and we're seeing a lot of capillary dropout in the periphery, so it intuitively makes sense that would mean that there's a reduction in the total retinal blood flow. Now, all of that is well and good, but what does it mean for you in the clinic, right? What does it mean when you're translating these findings into the clinic, and how can you actually use these to follow your patients up over time? And so I always come back to the question of, what are you using fluorescein angiography for in the clinical setting, right? So we used to use it to look at macular edema and to look at microaneurysms and to decide on focal laser treatment of microaneurysms, but we're not doing that anymore. So most of the time when I look at the top 3 indications of why I'm using fluorescein in diabetics in my clinic, I use it to evaluate patients for macular ischemia. I use it to look for neovascularization if I'm not sure if there's smaller fronts of neovascularization, and I use it for wide field imaging to look at the periphery and get an idea of how ischemic a patient's eye is. And so, to evaluate for ischemia, because we now have these automated parameters on OCT angiography, this is a good way of evaluating and getting early visualization of diabetic changes in the eyes, and to follow these patients up and to evaluate these patients for worsening. And we have good data showing that worsening, especially in the deeper capillary plexus, can be associated with an increased risk of developing diabetic macular edema. And so these may be patients that you want to follow up a little bit more closely. The other thing that OCT angiography allows you to do is it allows good structure-vascular correlation. So here's a 38-year-old uncontrolled diabetic patient of mine with a visual acuity of 2200 in the right eye. And as you can see over here, this patient has numerous small microaneurysms with some diffuse leakage around the macula, also has some neovascularization that you're seeing over here. Here's the patient's OCT and OCT angiography, right? So if you just follow this patient's OCT, you notice that with treatment with anti-VEGF agents, the OCT dries out nicely. However, the patient's still left with a visual acuity of 20/40. And so you wonder why that is, whether this patient needs more aggressive treatment. However, when you look at this patient's OCT angiography, you can see quite clearly that even though the edema is getting better over here, as the retina detergesses, the area of ischemia actually does not change. And so the reason this patient, a young 38-year-old patient, the reason why he's ending up with vision of 20/40 is just because he has macular ischemia. So, this nice structure-function correlation means that you don't necessarily have to resort to fluorescein angiography again and again on these patients, as you would have to do if you were now, stuck with this patient 6 months later with suboptimal vision. Vas alluded to this, OCT angiography does allow me to better monitor my proliferative diabetic retinopathy patients. So as you're all aware, areas of neovascularization are easily visible on OCT angiography, and they're these fine fibrillary vessels. Typically, you can see them best if you move your segmentation lines into the vitreous, because you can see them projecting out from the disc or from the larger blood vessels. And one of the huge advantages over fluorescein is that the margins are not obfuscated by leakage. So you can actually measure how big the CNV is, how big the retinal neovascularization is. And typically when I'm treating these patients with either laser or anti-VEGF therapy, I will look at the size of the neovascularization and evaluate it on OCT angiography to look for regression. And then I use these areas of neovascularization kind of like as VEGF meters in the eye. So I'll follow them up over time, and if over time I see eventually that after they've regressed, they start growing again, that's an indicator to me that this patient may need additional treatment, either with additional PRP or as we're doing more and more with more aggressive anti-VEGF therapy. Now, what can OCT angiography not do? So as of right now, OCT angiography does not get great wide field images, so it doesn't provide us with nice peripheral views of the retina. Now, technically, this is something that's doable, right? So this is something that we've demonstrated in the lab, where you can get images all the way up to the equator if you have a patient subject and you sit them down, you scan, and you scan, and you scan. But obviously, your diabetic patients who are in your clinic every 4 to 8 weeks is different from a very motivated MIT student who's looking for a great publication, and so you can't torture patients through this. However, having said that, with the ability to track with eye tracking and just with the improved speeds that happen with the faster swept source OCT devices, you are able to montage images together so that you're able to go at least up easily into the mid-periphery, taking just a few additional minutes of time. So this is a patient who had 5 images montaged together in this particular case, and you can see that we get a reasonable coverage, wide field coverage, and that this patient, and you get exquisite detail of the vasculature, unlike much more so than you would get in traditional fluorescein angiography. And these images are courtesy of Dr. Ricky Wang at the University of Washington. And as you can see over there, if you're patient enough and are able to montage enough cases, you start seeing the beginnings of these areas of non-perfusion, as well as this peripheral neovascularization, which is really what you're looking for when you're doing the ultra-wide field images on your Opta. So I think this is going to be another area of huge growth, where eventually we'll move from just being able to visualize the macula on OCT angiography to it taking off in terms of ultra-wide field imaging and giving us that kind of information. So I'm very briefly going to also touch on retinal vascular diseases, because a lot of what we do in diabetes also applies to retinal vascular disease. Professor Gur has already covered this, so I'm going to very quickly go through this. But in the case of retinal vascular occlusions, what I really find it useful for in the clinical setting is to make the diagnosis, but also to kind of get an idea of the level of non-perfusion and the area of non-perfusion, and to see how this changes with anti-VEGF treatment. And there are currently studies underway that look to quantifying vascular non-perfusion and seeing whether that can help predict the amount of therapy that you'll need in these patients. I think it's also really, really important in patients who have especially deep plexus ischemia. If you, after patients have dried out, deep plexus ischemia is associated with worse visual acuity, and that's been reported on OCT angiography. So I think this is another area in which OCT angiography is really useful. In this patient, for example, if you look at the superficial vasculature, not as much ischemia. You won't really be able to tell that this patient has somewhere close to 80 to 2100 vision unless you were looking at this deep plexus on OCT angiography, and you can really tell that the retina is very ischemic by looking at the deep plexus. And then, the third area in which it's enormously useful in vein occlusions is to look for optociliary shunt vessels and distinguish these from retinal neovascularization. So shunt vessels typically tend to be larger, they tend to be more substantial, and more importantly, they lie within the substance of the nerve and don't project up into the vitreous cavity, versus neovascularization, which tend to be finer, more fibrillary vessels and project into the vitreous cavity. So if you're ever concerned and or doubtful, or if you're looking for neovascularization in a patient who already has shunt vessels, OCT angiography can be really useful in helping you determine if there truly is neovascularization present in these patients. So to summarize, OCT angiography is a promising new approach to the visualization of retinal vascular pathology, and it's showing, things that that you can use it in the clinical setting on a day-to-day basis to get you information that can help guide treatment. It's non-invasive, fast, and repeatable, and allows us to monitor disease state over time. It allows for a nice correlation of structure to vasculature to better understand the pathologic basis of vascular eye disease and to help us better understand the visual acuities that we're getting in our patients. And certainly software enhancements in the future will allow for better evaluation of blood flow as well as a true wide field imaging in these patients. Thank you very much.